So, welcome everyone for the day 3 on the European meeting on HIV and hepatitis. So today's program will be 3 sessions. Session number 4 is managing of viral hepatitis. Then session 5 is what's in the pipeline, presentations from scientists in the industry. And the last session is session 6, prep and resistance. And we will start with session number 4, managing of viral hepatitis. It's a pleasure to announce Anna Maria Geretti from University of Liverpool, and she is giving a presentation on viral hepatitis. So.
Thank you. Starting with my relevant disclosures, and then our case study. 34-year-old man was recently diagnosed with a HIV infection and was also found to be positive for the hepatitis B surface antigen. Further tests show that he has chronic HBV infection. There is a very high global burden of a chronic HBV infection. Data from WHO showed that in 2018, there were 257 million carriers of the infection and nearly 900,000 deaths. From a global perspective, approximately 10% of people with HIV also have a chronic HBV infection with some geographical variability. It is well established that having HIV increases the risk of severe liver disease among people with hepatitis B. And we can see in this cohort study that was published in 2006 that liver-related death was the most common cause of non-AIDS death among people with HIV, and that hepatitis B co-infection was a significant predictor of liver-related death. So how do we assess chronic HBV infection at first diagnosis? We take a detailed history and a physical examination. We measure markers of HBV activity, liver and kidney function, coagulation, platelet count, alpha-fetoprotein. We don't forget about coexisting causes of liver disease, Hep C, Delta, steatosis, use of hepatotoxic agents, including alcohol. Check for hepatitis A immunity, take an abdominal ultrasound scan, primarily to check for liver cancer. Also measure fibrosis. We do this typically with a transient elastography, and some specific cutoffs have been proposed for liver stiffness in people with HIV and hepatitis B to determine the presence and degree of fibrosis. If possible, we also use the FibroScan to measure the controlled attenuation parameter in order to take a measure of liver steatosis. If there is advanced liver disease, we take a DEXA scan to check the bone mineral density. And then if there is a cirrhosis, we will also take an upper GI endoscopy to check for varices. How do we stage a chronic HBV infection? We use 3 markers, the E antigen, the HBV DNA, and the ALT. Patients who are infected vertically or at a very young age experience an initial phase of the infection that can last 2 or even 3 decades. This is the so-called immunotolerant phase. When the E antigen is positive, there are very high levels of HBV DNA and the ALT is normal. In the following phase, we see a disease activity. The E antigen is positive, the DNA is greater than 20,000 international units, and the ALT is persistently raised. This is E antigen positive chronic hepatitis B. In patients that continue during their chronic HBV infection, spontaneously they may lose the E antigen, or they may have started antiviral therapy and lose the E antigen during treatment. We then see a loss of E antigen. The ALT in patients who are untreated may decline to low or undetectable levels spontaneously, and the ALT becomes normal. This is the so-called inactive or low-level carrier stage of the infection. However, in some patients, as we know, it's possible for the virus to continue to replicate without expressing E antigen, and therefore we can have E antigen negativity with the HBV DNA level which is greater than 2000 and either persistently or intermittently raised ALT. This is active disease, also defined as E antigen negative chronic hepatitis B. The two groups with E antigen positivity or E antigen negativity that have disease activity are candidates for treatment in the context of hepatitis B mono infection. A couple of comments about the ALT. We use an upper limit which is a bit lower than the typical laboratory reference, 33 for men and 25 for women. And also, we need to consider that in the context of HIV, particularly in patients who are immunocompromised, the ALT may not be very high despite significant disease activity. When we assess for other causes of liver disease, we must not forget to test for hepatitis delta virus. Overall, 4.5% of people who are surface antigen positive also have hepatitis delta, and the risk of having hepatitis delta is actually much increased in people who also have HIV. Coming back to our case study, the E antigen is positive, the DNA is high, and the ALT is borderline. Other tests are not remarkable. However, we note that there is a degree of liver fibrosis and also a degree of liver steatosis. What next for our patients? Unlike the situation with the mono infection, in people who are co-infected with HIV, treatment for hepatitis B is recommended regardless of the degree of disease activity. And treatment is typically with agents that have dual activity against HIV and hepatitis B, i.e. tenofovir. We usually tend to use tenofovir alongside tricitabine or lamivudine. However, tenofovir per se is sufficient to treat hepatitis B. We recommend against using TTC or FTC alone against HBV because of the high risk of drug resistance. There are some key factors that influence treatment decisions. We take into consideration kidney function because it affects the use of tenofovir. There are also circumstances when it may affect the use of TAF. So, for example, we don't have sufficient safety data for TAF in patients that have a very low eGFR below 15 and are not on hemodialysis. We also consider bone health because it affects tenofovir use, of course, concomitant medications that may create a risk of drug-drug interactions. And it's also important for us to dig into the patient history and identify any previous history of lamivudine exposure without tenofovir, because this may lead to drug resistance, as we said, and also potentially affect the use of entecavir. Tenofovir is very effective in the treatment of chronic HBV infection. Most data are available for TDF. TDF is highly efficacious. It's also very effective against a virus that has accumulated TTC resistance. We see here HBV DNA responses in co-infected patients that had accumulated significant TTC resistance and then were treated with tenofovir as TDF. We can see that over 8 to 12 months, there was a sharp decline in HBV DNA levels in this population. HBV resistance to tenofovir is rare, although it has been occasionally reported. And overall, the long-term safety of TDF is good when compared to entecavir. For example, in the context of monoinfection, we have recently seen data spanning 7 years and showing that overall the safety profile is similar for TDF and entecavir, although renal tubular dysfunction is more likely to occur on TDF. What about TDF versus TAF? There have been 2 large studies that have compared TDF and TAF in monoinfection and showed that TAF was non-inferior virologically to TDF. Patients on TAF, interestingly, were more likely to show normalized ALT levels, and perhaps less surprisingly, also had smaller decreases in bone mineral density and also smaller changes in eGFR. There are also data for co-infected patients. For instance, in a study of 70 patients that switched suppressive ART to a TAF and FTC containing regimen, there were very high levels of HPV DNA suppression over 48 weeks. We may occasionally use entecavir. In this case, we must take into account the possibility of 3TC exposure and therefore 3TC resistance, because this may cause cross-resistance to entecavir. If there is only one lamivudine mutation, for instance, a 204V mutation, typically, then we may use entecavir at the higher dose of 1 milligram per day. But when there is more extensive resistance, then really entecavir is not our drug, and we should reassess the option of using tenofovir instead. So our patients were started on TDF and FTC alongside dolutegravir. How do we monitor the infection once treatment is started? Initially, we monitor the HPV DNA and the transaminases a bit more frequently. We would like to see at least one log decline in HPV DNA after 12 weeks, and most patients will achieve an undetectable HPV DNA within a year. Some may take a bit longer, up to 2 years. And in a small subset, actually, we may see a very, very slow decline, and they may achieve undetectability over several years, even up to 5 years of treatment. Once the HPV DNA has come down to undetectable and the ALT has normalized, if it was raised, then we can decrease the frequency of monitoring. We monitor renal and liver function as per standard requirements. And if the patient is e antigen positive, we also monitor for evidence of e antigen seroconversion about every 6 months. And then we stop if seroconversion occurs. Although, of course, we then retest for e antigen if there is a flag, for example, a sudden increase in HPV DNA or ALT. We don't forget about monitoring for fibrosis and steatosis. And of course, we continue to screen for cancer, because the risk of hepatocellular carcinoma is not abolished, although it is reduced by antiviral therapy and HPV DNA suppression. There are some difficult scenarios to consider, for example, what to do if the patient is still showing HPV DNA detectability and has been more than 2 years since the start of antiviral therapy, perhaps with a drug such as tenofovir. We get a bit more concerned if the ALT remains elevated. In these cases, we may consider a trial of intensification with entecavir, for example. We may decide to continue to monitor, because we know that a subset of patients take a bit longer to get undetectable, as we said, up to 5 years. But I would like to share one tip. If the HPV DNA is being monitored with a TMA-based assay, then we may want to ask for another assay just to confirm the viremia. And this is because we know now that in some patients who receive a very effective antiviral therapy and have a fully suppressed HPV DNA, there may still be circulating HPV RNA. And a TMA-based assay has an increased likelihood of detecting HPV RNA and reporting it as an HPV DNA signal. A resistance test is more informative for patients on entecavir. It's usually not very informative for patients on tenofovir. And of course, if there is any entecavir resistance, we must reassess the option of using tenofovir instead. So what about treatment duration? At present, treatment for people with HIV and hepatitis B is lifelong. We must remember the risk of rebound in case treatment is discontinued against hepatitis B. There is a risk of rebound. There is also a risk of significant severe hepatitis flares, and even liver failure has been described in the past in this co-infected population. The risk of rebound is due to the fact that the HPV replication cycle includes the formation of a mini chromosome, the covalently closed circular DNA, within the nucleus of infected hepatocytes. Antiviral therapy, tenofovir and entecavir, work on the reverse transcription of pre-genomic RNA into DNA prior to export of the virus progeny, but they do not really control CCC DNA, and therefore it's possible to have a rebound once treatment is discontinued. There is, however, a lot of research going on at present trying to develop drugs that will enable a cure of chronic hepatitis B. These studies are currently in phase 1 and phase 2. At present, they exclude people with HIV, but we certainly look forward to being able to offering new options for the control of hepatitis B to our co-infected population. Thank you very much.
Medicine and science is globally beneficial to public health and patient care. I mean, this is really a large capacity, one can say. So for the next speaker, we turn from hepatitis B to hepatitis C, and after the both two presentations, we will have a discussion, and of course, I understood we start with the poll, and then we go to the presentation from Francesca Ceccherini. And Francesca Ceccherini Silberstein is currently associate professor at the chair of virology and coordinator of the PhD course in microbiology, immunology, infectious diseases, and transplants at the University of Roma Tor Vergata. From 2017 is scientific director and vice president of the Italian Foundation of HIV Virology Italian Resistance Network Study Group, Fondazione Veronese. So, so again, how about the poll now? Is this in the first slide of?
Yeah, the poll's going.
The poll's going.
Hello to everyone. Best greetings from Rome. So today I will speak about the advantage to doing the resistance test. And we know that even if the majority of our patients are responding to the new direct antivirals, still few patients fail to achieve a sustained virological response, and some of those patients fail with resistance, and particularly in N5A target gene, and this resistance can persist for a long time of follow-up. We know that many factors contribute to the viral response of the treatment. Of course, the patient, the therapy, the drugs, but also the virus. And we know also that recently it has been shown that particularly some unusual subtypes can play a role also on the response. So this virus has high genetic variability, higher than HIV and hepatitis B. And we know that recently it has been identified also the 8th genotype. We know from the new EASL recommendation that still hepatitis C genotyping and subtyping is important for the choice and particularly the duration of the treatment. And we can see now in the new guideline a particular attention of hepatitis C subtypes inherently resistant to N5A inhibitors, such as these unusual subtypes that we say with like 1L, 4R, 3B, 3G, and 6UNV. That can be, have been associated to harbor natural resistance and to respond less in vitro to the treatment. So the first paper was from the group of Jean-Michel about the subtype 4R, where it was observed a higher prevalence of this subtype in individuals from African origin, and was a particular overexpression in the failures. And similarly, we know from London that there was a suboptimal SVR rate in African patients with atypical genotype 1 subtype. And so the issue of this unusual subtype has been also analyzed in our common share surveillance of hepatitis C antiviral resistance epidemiology and methodology database, and that has been presented at ASLD last year. And in the next time, in this afternoon, also Chiara Di Maio will speak about the unusual subtype prevalence in Italy. So we know since years that the resistance associated substitution are not really equally clinical relevant for the drugs and for the different genotypes. And also the prevalence as a natural resistance can vary according to the genotype and subtypes. And also that in vitro, there is a different impact according to the genotype and subtype. For instance, here is shown about the tyrosine 93H fold change for approved N5A inhibitor across the different genotype, and also how can be different with genotype 3B, for instance, where is high resistant to all drugs, including velpatasvir and pibrentasvir. And for instance, very recently, it has been published a paper where they did in vitro the replicon test expressing the N5A protein from unusual subtypes. And you can see the AC50 that is very variable and very high in different subtypes. And the best drug that in some way can be active is pibrentasvir, but still in some case you can see a fold change of between the different subtypes. And so according to this, you see that also the new guidelines suggest for patients that have this particularly subtype, the treatment with sofosbuvir, velpatasvir, and voxilaprevir, because it's very important to combine also a protease inhibitor. So the recommendation to do the resistance test before first-line treatment is not recommended, but in specific area where we know that some regimens that require optimization can be important to do the test. And we know, for instance, in Italy, we conducted a study on patients that have been naive with an outcome, and we saw that indeed, if patients at a baseline N5A RAS, the SVR rate was 73.7% versus 95% of all the other patients that did not have the resistance. So there is a role. That has been confirmed, particularly if the patients have not only the resistance, but also high viral load, cirrhosis, and presence of genotype 1 or genotype 3. After a failure, resistant test can help physician for the best choice of retreatment. And particularly the resistant test can help to understand why the patients fail. which are the possible cause of virological failure, including sometimes we saw the incorrect genotype, the presence of resistance at failure, and probably also natural baseline resistance if we have the samples, and therefore suboptimal treatment. At present, there is a limited documentation about the efficacy of retreatment after performing a resistant testing in patients who previously failed N5A inhibitor-containing regimens. But in these last years, several groups are working on this. So regarding the guidelines, the recommendation is that it's very important that the patients are retreated in the context of a multidisciplinary team, including experienced treaters and virologists, and the resistant test can support to guide the retreatment. Here is an example of a patient that is with genotype 3, that he has a natural resistance, but we didn't know before. But during the breakthrough, we analyzed that, that the patient has failing the GP with both NC3 and N5A resistance. And indeed, we observed that at baseline, these patients have natural resistance. And we decided to treat as early as possible to not interrupt the treatment and to continue the treatment with GP, adding ribavirin and after sofosbuvir. And finally, the patients achieve the cure. So for the retreatment, we know that the first choice of treatment is Vosevi for 12 weeks. For patients that have compensated cirrhosis, sofosbuvir, hepatitis plus riba for 20 weeks. But for particular patients that have some difficulty, the option can be with sofosbuvir and GP for 12 weeks, or for more difficult patients, also Vosevi plus riba or sof and GP for 16 to 24 weeks. Here, for instance, is our treatment and retreatment analysis of patients that failed the DA regimens that have been presented last year at SLD. And indeed, thanks to the resistant test, we managed to obtain a very high SVR rate, particularly to individual retreatment option. The lowest SVR rate was with sofosbuvir and velpatasvir because, as we expected, and indeed we have 6 patients that failed, but also 5 patients that failed with Vosevi without riba, while with riba, all patients achieve SVR. So adjusting, thanks to the resistant test, we could improve the efficacy. Just to say that for sake of time, I cannot show that it has been recently published a paper regarding the prevalence of resistance substitution and retreatment of patients that fail GP. And also at EASL this summer, we have several presentations, and these two are important regarding the patient that failed GP and Vosevi from the SHARE collaboration, and also real data about resistance to Vosevi retreatment. And just to mention that there will be a poster also here speaking about the Vosevi, the 40 patients that fail in Italy, Spain, and Germany of Vosevi. So my conclusion regarding hepatitis C resistance is that can be helpful before the first line treatment, because HCV sequencing can be useful to identify resistance, but also the correct genotype and the rare subtypes. And so the natural resistance, we know that frequently is present, particularly with specific subtype. So even if the systematic resistant test is not really recommended, but in some patients can improve the probability to achieve the virological response when there are other unfavorable baseline factors. And for instance, high viral load, cirrhosis, treatment experience, and particularly genotype and subtypes. And regarding the patients that fail, again, the resistant test can be very important to understand which were the cause of the virological failure, and can provide us particularly how is the level of the resistance, how is complex, particularly the N5A, and if there is multi-class resistance, that can advocate for tailored administration of drugs with different mechanism of action based on expert guidance. So The resistance test, to my opinion, can help to personalize the treatment like we are doing for HIV by increasing probability of response according to the resistance profile that we observed in the context of course, an experienced multidisciplinary team, because we need to always remember about the complexity of the patients and the virus. So I finish with thanking you for the attention and to thank all the collaborators that contribute in this year to obtain this very important data. Thank you.
Thank you very much, Francesca. That was really a lively vote. And now, before we come to any questions, we will switch to Jean-Michel Pawlotsky, who is telling us why we do not need any resistance testing. And after the two presentations, we will have a discussion, and then we will have a second poll. So Jean-Michel Pawlotsky, is professor of medicine at the University of Paris Est. He's director of the National Reference Center of Viral Hepatitis B, C, and D, and of the Department of Virology at the Henri Mondor University Hospital in Créteil, France, and director of a research team, Virus Hepatology Cancers at the Mondor Institute of Biomedical Research, INSERM U955. Focuses on teaching and research in virology, primarily on hepatitis viruses and liver oncology. So it's really a great pleasure to see you all, at least by screen. Hope we can do it next year again, face-to-face meeting. So Goda will keep us updated on that. But now we hear why we don't need resistance testing for hepatitis C anymore.
Good afternoon. Thank you very much for inviting me, and thank you for the introduction. I'm now going to discuss the cons of testing for hepatitis C virus resistance in clinical practice. This slide shows my conflict of interest disclosure. However, I have another conflict of interest to disclose, which is that I systematically do RAS testing before retreating patients who are exposed. However, I believe that it is possible to retreat with very high efficacy without doing it. The first point I want to discuss today is that we can avoid treatment failures by following strictly the final update of the EASL recommendations on treatment of hepatitis C. The simplified treatment strategy has been published together with the recommendations in the last issue of the Journal of Hepatology, and you can see here that it's possible to treat very simply without doing genotyping or subtyping, either with glecaprevir, pabrentasvir for 8 weeks or 12 weeks in patients who have cirrhosis and are treatment experienced, or with sofosbuvir and velpatasvir for 12 weeks. With this treatment, you will have very high SVR rate and very few patients who will fail on therapy. It is, however, possible to treat even better if you have access to genotyping, subtyping, and in the guidelines, it's clearly explained that reinforced strategies may further improve the SVR rates in patients who are more difficult to cure, patients who are infected with genotype 3 who have cirrhosis, and patients who are infected with genotypes or subtypes that are inherently resistant to hepatitis C virus DAAs. And this includes genotypes, subtypes that are present in some countries in Africa and Asia, and are also present in Europe in patients who are born in these areas. So the recommendation which is currently made for RAS testing in the EASL recommendations is the following: HIV resistance testing prior to retreatment in patients who failed after any of the DA-containing regimens is useful to guide retreatment by probabilities of response according to the resistance profile observed. This means that it is useful, but not that it's absolutely mandatory. And this is what I would like to discuss now. First of all, there are technical reasons not to use RAS testing prior to retreatment. The reasons are shown here. RAS testing is unavailable to the vast majority of HIV treaters, and this is particularly important in the context of extending the treater pool. More treaters mean more people do not have access to RAS testing. In addition, there is no standardization of RAS testing. Only one NGS-based standardized assay is currently available as a purchasable kit. Otherwise, it's only in-house sequencing methods that can be used, and many places don't have access to these methods. There is no standardized interpretation and reporting of HIV resistance data, and there are no clear-cut guidelines from international societies to guide treatment decisions based on RAS testing. The third point I want to make is that how to use RAS profiles prior to retreatment is pretty unclear. Indeed, there are two options. The first one is that treatment has not been optimal. It can be a treatment that has been given before the most recent recommendations at the time when the most recent DAs were not available, inappropriate choice of drugs, too short duration, poor adherence to therapy, all reasons to have a non-optimal treatment. And in that case, the RASes that will be present are highly predictable. So you can guess based on what the patient has received, what RASes will be present, and you don't really need to test for that. And then optimal retreatment strategies are likely to be highly efficacious based on this prediction of the RASes that are present. The second option is that you have followed the most recent EASL guidelines and treatment has been optimal. The patients have received pangenotypic regimen for the appropriate duration. In that case, the RASes that will be selected are very difficult to predict, and they are poorly predictive of retreatment outcomes. And therefore, the RAS profile in that case of optimal treatment and rare but possible failure will be very difficult to make. Just to illustrate this point, I want to show you the rates of failures that can be observed with sofosbuvir or hepatitis. It's a pool resistance analysis from phase 3 trials. You can see here that approximately 1% only of patients fail with RAS selected. The vast majority of them are in the group of patients with genotype 3, 2.5%, followed by genotype 1. And if we look at the RAS profiles observed in these patients, for genotype 1, you see different types of resistance substitutions selected in the NX5A region, Q30R, L31M, Y93N, Y93H, which are not really strongly predictive of what drug should be given. And we know that the triple combination is very likely to achieve an SVR in these patients. We have selected these RASes. And for genotype 3, the most frequent RASes were the A30K, the Y93H, but again, very poor predictive value on what retreatment should be given and the outcome of retreatment. The same applies to the combination of glecaprevir and pibrentasvir, and you can see here that the rate of failure is approximately the same, approximately 1% overall, vast majority again in patients infected with genotype 3, 2.8%, and less frequent in other genotypes. And here, again, we have a lot of different RAS profiles. They are different for genotype 1, genotype 2, and genotype 3, with different types of RASes, no homogeneous profile, and RASes selected in both the protease region, which is a target of glecaprevir, and in the NS5A region, which is a target of pibrentasvir. Nothing that can be used to say strictly this RAS predicts that the patient will need to be treated with this treatment or that other treatment and will surely respond. And therefore, this is not very useful to make a decision of retreatment. So the final point I want to make, and which is most important here, is that there are excellent retreatment options regardless of RAS profiles at retreatment baseline. These retreatment options have been listed again in the most recent EASL recommendations on treatment of hepatitis C. They include the triple combination of sofosbuvir, hepatitis and voxilaprevir, the triple combination of sofosbuvir plus glecaprevir and pibrentasvir, Sovelvox or Sof plus glecaprevir pibrentasvir with ribavirin, and it's also possible to extend treatment duration of the triple combination with or without ribavirin from 12 to 16 or 24 weeks in very difficult to cure patients. And we know that these retreatment regimens are very efficacious. We have results with sofosbuvir, hepatitis, voxilaprevir in 2 clinical trials, phase 3 clinical trials in patients infected with all genotypes. DA experience, approximately half of them with cirrhosis. On the left, the Polaris 1 trial, NS5A experienced patients retreated for 12 weeks with sofosbuvir, hepatitis B, or voxilaprevir with a 96% SVR rate, only 6 relapses and 1 breakthrough. And on the right, the Polaris 4 trial, which was in DA experience, but NS5A naive. They had been treated with other DAAs, and the SVR rate here is 97% with only 1 relapse. If we now look at the influence of pre-existing RASes on treatment responses in these 2 trials, this is a pooled analysis of Polaris 1 and 4 in these treatment experienced patients. You can see on the left all the experienced patients, all patients from 2 trials, and the influence of the presence of RASes on retreatment response. On the left, 98% SVR12 in patients who had no RASes at all. And on the right, the very same SVR rate, 98% in patients who had different types of RASes in the NS3, NS5A, or NS3 plus NS5A region. On the right of the screen, you can see the role of voxilaprevir and the hepatitis specific RASes. And again, there was no influence of the presence or absence of RASes on the response to Subvelvox, meaning that this retreatment is very likely to achieve an SVR regardless of the presence of RASes selected during the first course of treatment at the time of retreatment. Same thing now for the combination of sofosbuvir plus glecaprevir pabrentasvir. It has been tested in a phase 2 trial, the Magellan 3 trial. It is patients from phase 2 and 3 trials who failed a first GP treatment regimen, were retreated with sofosbuvir plus GP. And as you can see here, the SVR rates here are very high with a 96% overall SVR rate. There was only 1 relapse in patients, in a patient who received sofosbuvir plus glecaprevir pabrentasvir plus ribavirin. So if we look at the final recommendations on treatment of hepatitis C, it is clearly said that based on the results of the Polaris trials, sofosbuvir, hepatitis and voxilaprevir is the first-line retreatment strategy for any patient who failed a prior regimen with a DAA, with or without RAS, with or without RAS testing. There are potential reinforced strategies. A combination of sofosbuvir plus glecaprevir pabrentasvir is likely to have a higher, slightly higher barrier to resistance in the case of NS5A resistance, can be reserved to patients who have more advanced cirrhosis or other predictors of non-response to retreatment. And even reinforced strategies are available. These reinforced strategies include the combination of the 3 drugs, Subvelvox or SubGP, plus ribavirin, an extension of duration up to 24 weeks. And this is how we retreat our patients, either with Subvelvox first line or with more sophisticated reinforced strategies in patients who we think need a stronger, longer treatment. And so far, this has been extremely successful. In the past 6 years, I think we have retreated hundreds of patients and had only 2 retreatment failures in our experience. This brings me to my conclusion, and this conclusion is taken from the EASL recommendations, literally, and the retreatment in the recommendations must be guided either by the knowledge of which drugs were administered in previous treatment courses. If no resistant test is available, that will be the majority of cases where no resistant test is available, or, and this is what we do in my place, but it's a special place, if resistant testing is performed by probabilities of response according to the resistant profile observed and the treating team's experience, this is a plus, but again, it is not absolutely necessary. On this, I thank you very much for your attention.
So again, thank you very much. I think 2 excellent presentations on this highly interesting topic. So on one side, not too controversy, but on the other side, there are still some questions left. And still one of the main questions is, does resistance testing give us an additional safety? So if I understand this is correctly, that we can redo the polls, or do we have urgent questions to answer? Is this possible, Goda? Or shall we go to the voting? time for discussion now. Okay, so this gives us a few minutes for discussion. Are there any questions or arguments from Jean-Michel to Francesca or vice versa? And maybe I will start with one remark. How do we have to decide if we do with Vosevi 12, 16 or 24 weeks? Is this just by the history of the personal patient, or do we decide by the resistance profile? And if we don't have it, how do we do it?
Maybe I can answer that question because can you hear me?
Yes.
Yes.
Yeah. Because that was my conclusion. What decides about whether or not you use resistant testing is its availability and your ability to interpret the results. So I think, and we agree that, you know, the pros and cons is always a kind of artificial debate, but I think we fundamentally agree with Francesca that it can be done with resistant testing. It's helpful because it's interesting information if you can use it well. But the most important message really for most of the people who are listening to us is that if you don't have access to resistant testing, you can do very well, especially because treatment has been very simplified, that we have less and less patients who have been treated with the old regimens, and we have a very standardized and efficacious retreatment strategy right now. So you cannot fail. I agree, and Francesca will certainly build on this, that there is still an issue in HIV treatment with these unusual genotypes that are frequent in regions where resistant testing is absolutely not available, and may also be frequent in certain European cities where these people immigrate. But it's a different question, and I think the answer to that question is more in the epidemiology, knowing which of these unusual genotypes are frequent in a certain area and modify your overall treatment strategy, rather than trying to implement resistant testing in places where it will never work.
So this was already one hint to Anita's presentation coming later, and one argument or one hint to countries that are not so rich with the variety of different drugs. So we have limited sources and limited availability, access to the drugs. Do you think that kind of epidemiological resistance testing would be helpful in this setting, that we do know what certain rare genotype or special genotype is circulating and might be still sensitive to available or cheaper drug combinations instead of having the rich source that we have?
Francesca?
Yeah, no, first, if you don't mind, I wanted to comment before also the question of Rolf and the answer of Jean-Michel. First, congratulations for your presentation, because I think, as you said, you also believe and you do the resistant test, but I agree with you that it's very important as a message that when you don't have access to this, you should try to treat as best as possible the patients. But I think what still is difficult, at least in Italy, I don't know how it's in France, the retreatment in this moment in Italy is fixed, was every 12 weeks. And honestly, about this, I have a little bit some doubt for patients that have, since we are doing the resistant test, and we know that some of the patients have complex resistant patterns, and for instance, high viral load, you don't think that for some patients to go just with a choice, one choice, 12 weeks is too short. And so this is the reason why, at least in Italy, we are doing in our network to do the resistant test just to try to individualize, since few patients are failing, few patients, luckily. And I think it is very important to don't do just one treatment 12 weeks. This is so I wanted to hear this opinion to you, because in Italy it's very difficult to retreat the patients, and for instance also how the patients fail after Vosevi, how to do the retreatment. So even if are few patients, this is quite a difficult issue.
Yeah, you're right. I think we really have to help, and it's good that you came back on this, because maybe my answer to the question was not complete. The question is, how do you choose between sub-Velvox or sub-GP, or with or without ribavirin, and the duration? And one part of the explanation is you should use your experience. And I think the recommendations are pretty clear. A simple retreatment. Patient has been exposed to a previous version of the DAAs, has failed, or patient who have failed on sofosbuvir and velpatasvir can be easily retreated with sub-Velvox. A patient who failed on GP should be retreated with sub-GP. And then any patient who has signs of poor prognosis, such as very advanced liver disease, not decompensated, but cirrhosis with a high fibroscan, or patients who have already been multiply treated, these patients are less likely to respond to 12 weeks of sub-Velvox. And in these patients, we would then, without knowing resistance results, we would tend to treat them for a triple with ribavirin, and possibly for a longer duration. And again, this is based on experience. So I think retreatment does not absolutely need RAS testing, but it needs to be discussed by an experienced team. So it's not necessarily something for a first-line treater. We know that simplified therapy first line can be done by many people, and extending the treater pool is very important. Then, whether you have or not resistant testing, having a discussion with people who are used to retreat these patients is important, because they will know what to do with these patients.
Okay, thank you. So there are some questions from the audience, and I think we could combine some of these questions. If there is a convenient method to detect uncommon subtypes, or specifically genotype 3, Anita is asking, and another a question comes from Slim Forati, going into this similar direction, saying that do we need still genotyping, especially in African, Asian countries? And here again, I would come back to my remark from before. Is it possibly helpful to do kind of sequencing as an epidemiological tool to see what is going around? So if you go to Georgia and you just do genotyping with a simple genotyping test, then you might get a prediction for a certain genotype. But you know, in Georgia, we have a high prevalence of the St. Petersburg variant. So this gives the chance for both ideas to combine epidemiological research and typing, and to likely predict pre-existing resistant variants to certain drugs, disabling some of the drugs in these countries. So if
Rolf, yes, you asked
comment
me
that.
before. Yes, excuse me, you asked me and Jean-Michel to just need to reply. So I fully agree with you. And I think still some commercial assay have some problem to provide the subtypes in addition to just the subtype 1A and 1B for the genotype 1. So must be very important, this type of epidemiological study, according to the analysis of the commercial assay and some sequencing data to do a survey and in a different country, even if preliminary we know almost, but not complete. So I think it's very important to do this type of study and share, for instance, where we listen later, Anita, she's leading this. So I think it's a very important subject on this, yes.
So thank you very much. Before we come to Anita's presentation, we now redo poll to see if we convinced the audience to do or not to do the resistance testing. So the poll is open. Is this correct, Goda? Okay. So the vote is going on. And if nobody comes to it, seems that now 75% agree, or 80% even agree on resistance testing prior to treatment, and 20% disagree, and there was no undecided. Oh, no, still changing. So seems that still the majority is in favor of resistance testing. Maybe we can announce the final voting at the end. So Anita, there's a bit of pressure on you on the phylogenetic epidemiological talk. So to announce Anita, she's senior scientist at British Columbia Center of Disease Control in Canada. And her primary research interests are antiviral drugs and drug resistance, together with the collaborators from multiple countries. That's true. So also Francesca and me are collaborators. They have set up an international consortium, shared, to monitor and characterize HIV drug resistance and transmissions. And me personally, I can say that we are happy to share data and knowledge with Anita. So just a short CV, she received her PhD in medical microbiology and immunology in the University of Alberta, Canada, so still Canada, where she studied nucleoside inhibitors against hepatitis B. And after postdoc fellowship, she studied HIV at Harvard Medical School and joined the Pharmaceutical Center, led the drug discovery and clinical virology teams to develop several HCV drugs currently used in the clinics. In 2015, Anita Howe returned to Canada and joined the Center of Excellence in British Columbia in HIV and AIDS. She and her team developed the whole genome HCV next generation sequencing for drug resistance testing across Canada. So whole Canada is now in your hands with drug resistance respect to HCV. Anita, is that correct?
Good afternoon. Thank you for the opportunity to share with you our recent experience with HCV Next Strain. It is a privilege to speak on behalf of all SHARE members who contributed to the data and scientific expertise. Today, I would like to share with you some of the features and capabilities of the HCV Next Strain. The Next Strain platform was originally developed by GSAP for monitoring influenza viruses and recently for COVID. We adapted this platform to display HCV drug resistance and transmission. This project is work in progress, and I look forward to hearing your suggestions for improvement. So let's get started. There are three display panels in the HCV Next Strain: the phylogenetic tree, the map, and the diversity pane, where it shows the open meeting frame of NS5A at the moment. In the theory panel, which is located on the left, we have built in many different functions to characterize HCV drug resistance. In this demo version, I only included a small subset of sequences from Germany, Italy, Spain, and Australia. Let us first look at the genotype distributions. In the phylogenetic tree, you can see that the sequences are nicely grouped into genotype 1A, 1B, and genotype 3. We only have a few sequences in genotype 4 and genotype 6. And the genotype 2 sequences are located at the bottom of the tree. In this cohort, we grouped the patients into 5 age groups: those who were 75 or older. The boomers are between mid-50s to mid-70s, and those in Generation X are mid-40s to mid-50s. Generation Y are mid-30s to mid-40s, and Generation Z are mid-20s and younger. As you see from the map, over half of the patients in Germany and Italy are baby boomers or older. The cohort population in Spain and Australia are a bit younger. By expanding the geographic resolution, we see that the population is relatively young around the metro area in Sydney. Specifically, there's a cluster of patients of mid-40s or younger. This is a town called Woodman, where there is a prison facility, and this is where most of the samples came from. Let us take a look at the treatment and virologic profile of these patients. The regimens are color-coded based on the NS5A inhibitors. Notice that in genotype 1A and 1B, most of the patients were prescribed with ladipasvir followed by ombitesvir. There are a small number of patients treated with elbasvir and dacarbazine. In the patients who were infected with genotype 3, there is an even split between velpatasvir and dacarbazine. Interestingly, there seems to be a preference for prescribing dacarbazine in Italy and Australia. This might have reflected prescription preferences and the reimbursement policy of the respective countries. In terms of treatment history, there is almost an equal proportion of treatment experience and treatment naive in the three countries in Europe. For the patients in Australia, most of them are treatment naive. You can also examine a specific subgroup of interest using the filters at the bottom of the display panels. For example, you might be interested to look at the treatment response, specifically the sustained viral response between two groups, the treatment experience with cirrhosis versus treatment naive and without cirrhosis. After selecting the filters for the treatment experience and cirrhotics, here we can look at the top of the screen. And there is a viewing counter. Here we see that 69 subjects who are treatment experienced and cirrhotic achieved sustained viral response. Let us take a look at the treatment naive and non-cirrhotics. Here we see that almost twice as many of the treatment naive and non-cirrhotic achieve sustained viral response as compared to the treatment experience in cirrhotics. And there is 151 patients here. Suffice it to say, we are interested in the characteristics of drug resistance mutations and their potential transmission. In this program, we have built in 3 different functions to look at if the subject has selected drug-resistant mutation, the number of mutation, and the resistance patterns. Let us take a look at their follow-up time points. As shown in the pie charts, for subjects who failed DAA therapy, over 80% of these subjects selected drug resistance mutation. This is quite consistent in all 4 countries. You can also see how drug resistance mutation was developed over time in a little movie. In this data set, drug-resistant viruses were first observed in Brisbane, Canberra, Adelaide, Sydney, North, Italy, Germany, and many cities. There is an expansion of drug resistance due to the increasing usage of DAA in the last 5 years. Next, let's take a look at the number of mutations. As seen from the pie charts, most of the DAA failures selected 0 to 2 resistant mutations at the follow-up visits. Please note that most of these DAA failures were infected with the epidemic strains, such as genotype 1A, 1B, and genotype 3A. For those who were infected with uncommon genotypes, we can once again use the filter to look at the virology profile of these subjects. Here, I am selecting genotype 1I, 1K, 1L, etc. When I said uncommon genotypes, What I meant was that they were uncommon in developed countries where most of the clinical trials took place. They might be common in other parts of the world, but we have not studied them extensively. Now I have selected my whole collection of uncommon subtypes and genotypes. Let's take a look. Comparing to the epidemic strains, which normally selected 0 to 2 mutations, patients infected with the uncommon genotypes tend to select multiple numbers of mutations, 3, 4, 5, 6, and 7. Lastly, let us look at the resistance patterns. Here is a list of resistance patterns in decreasing order of prevalence. The use of filters, again, is a powerful way to visualize drug resistance patterns. For example, here we see that mutation 93 is present in all genotypes. However, when we choose another very common mutation at position 30, we find that this mutation is primarily selected by genotype 1A and genotype 3. Mutations at 93 and 31, however, is exclusively selected by genotype 1B. The visual display coupled with filters allow us to examine drug resistance patterns in any specific subgroups with only just a few clicks. Finally, let us also examine the potential transmission clusters. Let us look at the East Coast of Australia. Here we have quite a few genotype 3 sequences from the Australian dataset. You can double click the node at the base of the tree to expand the tree. And if you are interested in the area of sequences, say around here, you can also double click it to further expand it. You can relay the sequences with the geographic location by mousing over the cities. If you have some sensitive information that are not PV to the public XCV next string, but you want to examine this information in relation to the phylogenetic network and the geographic location. For example, if you have information on injection drug use, ethnicity, HIV, gender, etc., all you need to do is to drag this file into the XCV next string. This can be done in the absence of internet. You can also share the XCV next string display the JavaScript with your colleagues. Your collaborators can see the displayed from their desktop. Once again, all they need to do is to take the JavaScript that you send them, drop it into the auspice.us site. And here I have a full-length XCV instead of the NS5A. I hope you find this platform interesting. I think this platform can also be useful for monitoring HIV drug resistance and transmission, especially in the area of new integrase inhibitors and long-acting regimens. If you have any questions or suggestions, or you would like to contribute your data to put onto the map of the XCV next string, please contact me at anita.howe@bccdc.ca. Thank you very much for your time and attention.
Thank you very much for this excellent talk. And as I already asked before, you addressed some of the epidemiological questions. So to combine our questions before and now to have a look on epidemiology. But before we come to precise questions to your talk, I would like to say the results from the poll. And so 88% of the people voted to agree, yes, we do resistance testing before treatment. Disagree 12%, and no one was undecided. So these are the results. So the winner is unfortunately Jean-Michel. The winner is Francesca, saying yes, it is good to do it. But I think you very precisely addressed one question, that indeed retreatment is not so easy, and it should be performed either in a good and professional team, or if possible, to use some additional markers from resistance testing, etc. So are there any comments to that from Francesca and Jean-Michel? But please, only very shortly. We want to come and discuss Anita's talk.
Just one comment. I'm not sure we know exactly what question was answered. So can you read the question again to know what people agree with exactly?
Yeah, I think that they agree that the final message is that to retreat the CVDA filers without resistant testing is possible. So it's exactly.
I was wrong. Yeah.
Exactly, Rolf. I wrote you also the.
So I was completely wrong. So sorry for that. Yes, it is possible to retreat DAA failures without resistance testing,
Yes.
and the majority votes for this, and only the minority needs resistance testing to do this.
Yeah.
And we both agree with that.
Yes, yes, exactly. So I agree. I like it very much your final points, that at least it's very important that in the context of a multidisciplinary team. And if we can have, I think all of us agree, if we can have the resistant test is good, but it's not essential. I agree. But we need to discuss patient per patient. So we should go, I think we both agree, I think, Jean-Michel, to do the personalized treatment for these patients that are difficult to treat. Of course, can provide an added value, the resistant test, but it's not essential. This was your point, no?
Absolutely.
So now we cleared my mistake. Again, sorry for that. And we come to Anita's presentations. Are there questions to Anita's talk? And again, thank you for this really impressive interactive data on the internet. So are there questions to that? If not, are there any restrictions to use this interactive map, Anita?
There is really no restriction to use the interactive map. And after discussing with our steering committee, and specifically Jean-Michel and Francesca, we decided to have two versions of the XCV next string. The one version will be open to public, so everybody is welcome to use it and view it. And it's very easy and well documentation from the GSAT site that they can even download some of these display for their, say, education or presentation. And then there is a second, more detailed display for the XCV next string. And as what I pointed out, some of the very detailed information, which could be quite sensitive. And that will be require an account access. And if people who, particularly the share members who want to get access, and they can write to me, and I will set up the account. And currently we have set up a secure platform at the University of British Columbia. And so I will set up an account with a password so that they can view all this information. And by the way, the project is still work in progress, and I have to put all the data together.
Okay, by this I already apply for a password, if possible. Thank you very much, Anita. And now we come to abstract-driven presentations. There are 3 in a row now. This is from Evangelia Georgia Kostaki. molecular analysis of HCV subtype 3A dispersal patterns among inmates in Greece. HCV transmissions are not related to incarceration. Oh, sorry. Then we have from Velia Chiara Di Maio, characterization and resistance profile of unusual hepatitis C virus subtypes in Italy. We heard of that already a bit from Francesca. And the third one is also from Italy, Lorenzo Piermatteo, and highly sensitive digital droplet PCR assay allows to reveal cryptic HBV replication in anti-HBC positive HBV S antigen negative patients with HIV infection. So then we come to the first of the abstract-driven presentations. Thank you very much.
Good afternoon. I'm going to present you the results of our study, which is a molecular analysis of HCV subtype 3A dispersal patterns among inmates in Greece. HCV is a global public health problem. As in the most countries of the Western world, in Greece the most common mode of HCV infection is through injection drug use. HCV has been phylogenetically classified into 7 major genotypes and 86 subtypes. The global prevalence of HCV was estimated to be 1% in 2015. This percentage corresponds to 71.1 million viremic infections. Genotypes 1 and 3 were the most common causes of HCV infections in a global scale. A recent review by Dolan et al. Showed that the prevalence of HCV is higher in prison populations than in the general population, mainly because of the criminalization of drug use and the detention of people who use drugs. In Greece, genotype 3 is the most common cause of HCV infections in people who inject drugs with chronic hepatitis. A recent molecular epidemiology study on sequences sampled in Athens, Greece, revealed that most sequences of HCV subtypes 1A and 3A fell within IDU-specific monophyletic clusters. The high proportions of HCV sequences within these clusters suggest that transmissions occur locally among injectors in Greece. The numerous clusters for both 1A and 3A subtypes provide evidence that both subepidemics were the result of multiple introduction among the injectors. Recently, a test and treat program for viral hepatitis, HIV and tuberculosis took place in a detention facility in Athens. In the context of this program, the prevalence of HCV antibodies in inmates in Athens was estimated 85%. Although HCV infection is more prevalent among inmates, to date it remains largely unknown whether incarceration contributes to the spread of HCV. Our aim was to investigate the HCV transmission patterns among inmates with prior injection history in Athens, Greece, using molecular epidemiology methods. The study population was consisted of 117 anti-HCV positive inmates in Athens, Greece, who participated in the test and treat program for viral hepatitis, HIV and tuberculosis conducted between 2017 and 2018. HCV genotyping was performed by HCV typing tool. Phylogenetic analysis was performed in the sequences of the most prevalent HCV subtype in our sample in 2 steps. Firstly, we analyzed phylogenetically the 51 subtype 3A sequences from inmates, along with 519 subtype 3A sequences from HCV chronically infected patients in Greece, and also the most closely related sequences sampled globally and from Greece. The blast search was run against global and Greek dataset using as a query the sequences from the inmates. The identification of inmate-specific clusters was based on phylogenetic analysis performed by the appropriate maximum likelihood method. Secondly, the inmate-specific clusters identified by the maximum likelihood analysis were further confirmed by a Bayesian analysis, which was performed separately for each cluster, along with the most closely related globally sampled sequences after using the BLAST tool available at the NCBI database. Finally, the phylogenetic clusters including sequences from inmates at proportion greater than 50% and receiving SH value and posterior probability support greater than 0.9 were considered as inmate-specific clusters. In addition, we perform molecular clock analysis in the largest cluster to estimate the time of the most recent common ancestor. Let's proceed with the results. Genotyping analysis revealed that 3A and 1A were the most prevalent HCV subtypes in our study sample. In the following slide, we may see the phylogenetic tree of the subtype 3A sequences. Sequences from Greece are marked in red and green. With green color are those from inmates in Athens, while with red are those from chronically infected patients in Greece. In addition, globally sampled sequences are marked in gray. Focusing on the subtype 3A sequences from people who inject drugs in inmates marked in green, we may see that they are clustered at different points in the phylogenetic tree. Specifically, the phylogenetic analysis using two different approaches showed that 6 sequences from inmates clustered in 3 inmate-specific clusters consisting of 2 sequences each, and 12 sequences from inmates were found within a cluster of 26 sequences from Greece. Overall, only the 11.8% of the sequences from inmates were found within clusters. Within the larger cluster of the 26 sequences, no significant clustering was found for the sequences from the inmates. Furthermore, the time of the most recent common ancestor of the cluster was estimated in November 2013, suggesting that most HCV transmissions within these clusters occurred recently. These results are in accordance with our previous findings for subtype 1A. Subtype 1A is the second most prevalent subtype in inmates in Athens. Phylogenetic analysis on subtype 1A sequences has shown that a small percentage of 1A sequences from injectors in inmates cluster together, suggesting a common origin of HCV infection. So as to conclude, our study showed that only 11.8% of the 3A sequences from inmates cluster together. This finding suggests that a small proportion of inmates share a common origin of HCV infection. This percentage should be interpreted as the upper limit of HCV transmissions among the inmates if we consider that the possibility of unsampled intermediates cannot be excluded. In addition, even in the largest group of the 26 sequences, no clustering was found among the inmates, thus provides further support to our findings for low-level HCV transmissions within this population. Finally, these results are in accordance with our previous findings for the subtype 1A. Taking all of this into account, we may conclude that incarceration is not associated with HCV transmissions in Greece. I would like to thank the Scientific Committee for the invitation, our colleagues for their collaboration, and of course all of you for your attention. Thank you.
Good afternoon, everyone. My presentation today concerns the characterization and resistance profile of unusual hepatitis C virus subtypes in Italy. As we know, hepatitis C virus is classified in 8 genotypes and more than 100 subtypes. Subtypes 1A, 1B, and 3A are the most prevalent worldwide. Instead, there are unusual subtypes considered as less common in Western countries that are comparatively rare and circulate in more restricted geographical areas such as endemic strains. Moreover, Italy has a unique GT2 subtype profile with a high prevalence of GT2C. This subtype is less common in other countries and is poorly characterized in terms of its resistance profile to direct acting antivirals. More attention has recently been given to unusual HCV subtypes since some studies have shown that some of these had a lower response rate to DAs compared to the other most prevalent subtypes. Most of these unusual subtypes are characterized by the presence of several polymorphisms in the NS5A region, which can impact the efficacy of NS5A inhibitors as recently suggested by in vitro studies. So, starting from this observation, the aim of our study was to investigate the prevalence and resistance profile of unusual HCV subtypes in Italy, including GT2 subtype C. This is a retrospective study where we analyzed the clinical and virological data of patients infected with unusual HCV subtypes defined as GT1 non-A or B, GT2 non-A or B, GT3 non-A, and GT4 non-A or D, which we collected from the Italian resistance database Virology C. The subtype assignment was confirmed by phylogenetic analysis on sequences available, and the prevalence of resistance-associated substitutions was evaluated at key position following literature data, focusing the attention on the NS5A region. This is the HCV genotypes subtypes distribution within the Italian resistance database Virology C. As you can see, among 3,469 patients with at least one amplified sequence, the majority were infected with GT1 subtype A or B and GT3 subtype A. 9.8% of patients were infected with unusual HCV subtype, including the GT2C. In particular, the majority of patients were infected with the subtype 2C, which, as I mentioned before, is common in our country, while other unusual subtypes had a prevalence lower than 1%. And as you can see in the histogram, a higher level of differentiation was observed, particularly in the context of the GT4. A different geographic distribution of these unusual subtypes was observed considering the patient's country of origin. In particular, GT2C and GT3H were mainly found in patients from Italy, while the other unusual GT3 subtypes were found predominantly in patients from Asia, and unusual GT1 and GT4 in patients from Africa. This is in line with the common distribution of these subtypes in these geographical areas. Among the 342 patients infected with unusual subtypes, 261 were DA naive and 81 were DA failures. More specifically, patients with GT1 unusual subtypes were especially present in the DA naive population, while GT3 and GT4 unusual subtypes were mainly represented in DA failures, with a high prevalence of subtypes GT3H and GT4R. Considering GT1 unusual subtypes, we had mainly NS5A sequences available for DA naive patients. We observed that all 5 GT1 unusual subtypes analyzed showed natural polymorphism in the NS5A. In particular, GT1G showed natural polymorphisms involving position 93. The only GT1L failure analyzed had the same substitutions observed in the GT1L DA naive, involving position 24, 31, and 58. For GT3 unusual subtypes, NS5A sequences were available mainly at DA failure. We observed that some GT3 failures showed NS5A patterns involving 2 or more substitutions. In particular, subtypes 3B and 3G showed the pattern A30K plus L31M, which was shown in other studies to be naturally present in these subtypes. The only GT3K analyzed which failed a GP regimen showed that failure a complex pattern involving several positions, including the positions 30, 31, and 93. Considering the GT3H failures, 4 out of 7 showed resistance at failure, involving in the majority of cases only the position 93. In GT4 unusual subtypes, we observed that all the 9 DA naive patients showed at least one natural polymorphism, always at position 30. Considering GT4R, which was associated in other studies with DA failure, we observed that both DA naive and failure showed the triple NS5A pattern L28M plus L30R plus M31L. Lastly, in GT2C, we analyzed 246 NS5A sequences, 197 from DA naive and 49 from DA failures. Furthermore, among DA naive, we selected 89 patients who had information available regarding DA treatment and all achieved a sustained virological response. We identified several NS5A polymorphism at key position at failure, and we subsequently evaluated its prevalence in the different groups. We observed an increase in prevalence at failure only for the polymorphism F28C. By analyzing the distribution of this polymorphism for the specific DA regimens, we did not observe a different distribution among DA naive with a sustained virological response and DA failure, considering the new combinations such as GT and Sofvel, while a high prevalence of this polymorphism was observed only at failure with the soft-duck combination and 3D. In conclusion, using the Italian resistance database ViroNet-C, we provided a characterization of unusual HCV subtypes circulating in Italy. We observed that 9.8% of patients were infected with unusual HCV subtypes, including the GT2C. DA naive patients infected with unusual GT1 subtypes carry several natural NS5A races. The majority of DA failures infected with GT3 or GT4 unusual subtypes showed complex NS5A RAS patterns, some conferring a high level of resistance. The majority of GT2C failures with new recommended regimens did not show specific races at failure. F28C was associated only with DA not currently recommended. Further studies are needed to better characterize the impact on the efficacy of these unusual HCV subtypes, particularly for the new regimen and subtypes with natural complex races. I would like to thank all the members of the Italian network for their collaboration in the study, and I would like to thank you for your attention.
Good afternoon to everybody. The 7% of HIV-infected patients harbor chronic hepatitis B infection, and this value increases considering the anti-core positive HBsAg negative patients. This condition is associated with an increased risk of liver disease, higher mortality related to AIDS events, and a poor HIV replication control. Moreover, in these patients, HBV DNA can be present at very low concentration, not detected by commercial assays. In this light, this study is aimed at investigating Cryptic HBV replication using innovative and highly sensitive assays, at determining factors associated with its detection, and at defining the role of serological markers in predicting Cryptic HBV replicative activity in a population of anti-core positive HBsAg negative HIV infected patients receiving HBV active antiretroviral therapy. To achieve these aims, 81 patients were included. All patients were HIV-1 positive, anti-core positive, HBsAg negative, and combined antiretroviral therapy experienced with at least one anti-HBV drug. And all patients showed serum HBV DNA lower than 20 international units per ml by commercial assays. Moreover, for each patient, the quantification of cryptic HBV DNA was performed by an in-house highly sensitive droplet digital PCR assay. This in-house assay shows a good linearity ranging from 1 up to 10,000 international units per ml, and a good intra and inter-run reproducibility and high sensitivity. Furthermore, serum HBV RNA was quantified by an Abbott research assay with lower limit of quantification of 1 in 65 log unit per ml. Indeed, serum HBV RNA is known to correlate with the intrahepatic cccDNA and pregenomic RNA, thus reflecting the burden of intrahepatic HBV reservoir. And the assessment of anticore titer by Fujirebio assay. Anticore has been proposed to reflect the burden of HBV intrahepatic reservoir in anticore positive patients.
The table reports the characteristic of the study population. All patients were anticore positive and HBsAg negative with serum HBV DNA lower than 20 international units per ml. Moreover, patients showed normal median ALT, and the 17% were anti-HBs positive, with a median titer of 277 milli-international units per ml. Regarding HIV, most patients were virologically suppressed, so with HIV RNA lower than 20 copies per ml, indicating the virological success. Moreover, most patients were treated with combined antiretroviral therapy containing TAF or TDF with emtricitabine.
Moving to the results, the cryptic serum HBV DNA is detected in the 30% of the population by using the in-house droplet digital PCR assay.
The detection of cryptic serum HBV DNA significantly correlates with advanced CDC stage and with lower anti-HBs titer, supporting the role of immune suppression in favoring the viral replication.
Moreover, cryptic serum HBV DNA tends to be more frequently revealed in patients experiencing HIV virological failure, and a positive correlation is observed between cryptic serum HBV DNA and HIV viremia. These data are in line with the recent Italian study where the authors observed a correlation between anticore positivity with poor HIV replication control during therapy. Regarding HBV RNA, in the overall population, the 4% of patients shows detectable serum HBV RNA, further supporting an intrahepatic HBV activity in these patients. Furthermore, HBV RNA positivity is correlated with lower Nadir CD4 values, again highlighting the role of the immune responses in controlling the transcriptional activity of intrahepatic HBV reservoir.
The last step of this study was to define the role of serological markers in predicting cryptic serum HBV DNA. In particular, we focused on anticore titer proposed to reflect the presence of an active intrahepatic HBV reservoir, and on anti-HBs titer reflecting the extent of the immune response against HBV.
In particular, we found that the combination of anti-HBs titer lower than 50 milli-international unit per ml and anti-core greater than 15 COI predicts the presence of cryptic viremia with a positive predictive value of 63% and a negative predictive value of 72% and a diagnostic accuracy of 73%. In conclusion, this work shows that droplet digital PCR represent a valuable system for highly sensitive detection of serum HBV DNA. In the setting of anti-core positive, HBsAg negative, HIV positive patients, cryptic HBV viremia is detected in not a negligible fraction of the population and correlates with advanced CDC stage and lower anti-HBs titer, supporting the role of immune suppression in favoring viral replication, and is frequently revealed in patients experiencing HIV virological failure. Moreover, the presence of serum HBV RNA correlates with lower nadir CD4 cell count, again supporting the role of immune suppression in promoting viral replication. And the combination of anti-HBs and anti-core titers can be useful in predicting cryptic viremia and in turn in optimizing HBV occult diagnosis in the setting of HIV co-infection. And in the end, the integration of innovative serological and virological markers can help in optimizing the monitoring of anticore positive HBsAg negative patients. I would like to thank all the co-authors for their precious collaboration and you for your attention.
Thank you very much for these three really interesting talks. And before we come to questions to these talks, we should go back to Anna Maria's talk on hepatitis B. And there was one question from Stefan Dressler on a drug that was developed actually in Germany already a long time that this drug has taken. It was first called Mirclodex, and then Hepcludex, and now it is, what is the official brand name now?
Hepcludex, I think is the name, right?
What?
So it's called Bulevertide, but the trade name is Hepcludex.
Oh, that way around.
Hepcludex, yeah.
Okay, so it was a question, how far is that drug? And to my knowledge, it has been approved for hepatitis D patients.
Correct. Yes, it's been approved for the treatment of hepatitis delta, either as monotherapy. The approval at the moment is either as monotherapy or in combination with tenofovir, with data showing better responses if given in combination with tenofovir. But the development continues because, of course, we are not there yet. So the using monotherapy or in combination with tenofovir does achieve a reduction in hepatitis delta RNA levels in about half of the people treated, and also normalization of ALT accompanies the decline of the RNA. But how long should you then, treat for? Rebound is very common, and so the use in combination with tenofovir at the moment, if you read the license, it says, to be continued until there is clinical benefit. So the duration is unclear. But the development of the drug continues in Germany as well. There is an international program, I think across Europe, America, and also Russia, looking at the combination, for instance, with interferon. And we have seen the initial data being reported and showing that sustained responses, i.e., basically suppression of delta RNA that is maintained after the interruption of treatment, can be achieved in a good proportion, not 100%. I think it's about half again or so, of patients that use it in combination with interferon for 48 weeks. So there were data showing that the response can be sustained. So we need to keep watching. At the moment, I think the use in combination with tenofovir, of course, is within the license. The data that support using interferon are pretty convincing. But the development is still ongoing from that point of view. So how will I use it? How would I use it? I would try to use it in combination with interferon. I think that will give me probably the best chances of a durable response.
I remember there was a debate on the concentration of interferon. So this is still a very interesting and ongoing subject. And thank you for adding hepatitis delta on this conference, Anna Maria. Thank you very much for that. And I think it is an ongoing topic that we can come back when we are allowed to meet again next year, if we have a time after COVID. So
let's hope so. It's an interesting topic, so lots to cover. And there are other drugs as well that are in development. So
so this is really mentioning for the next workshop. So coming now back to the other presentations, if I may, there was a question from Anita about drug injection use that we wanted to discuss. And please correct me if I overlooked other questions from the audience. If that's not the case, here the question was, is it possible, or do the inmates perform drug injections in prison? So, and what is the problem about that, practical problem? So that was a question from Anita to all. So what is the experience? The answer from Evangelia was, officially it is not allowed. Of course it is not allowed to use drugs in prison. Sure, but we all know that this happens and the purity of the substance is on question. So what is your opinion on that? Is it a problem in Britain, France? Definitely it is in Germany, I can say that. What about France, Jean-Michel?
I was restoring my audio. So the question is it allowed to use drugs in prisons in France?
No. Not, and the question was, does it happen?
It does very much, because prisons are a place where people use drugs, and more than in any other place. You should find this abnormal, but it does happen, definitely.
Yeah. And by that, we distribute also hepatitis B, C, and possibly HIV, right?
Yeah, but we also have now HIV treatment, and these people have access to prevention, on-site screening, and a lot of treatment as well. So expanding access to care is important in prisons.
Yeah.
If you cannot stop people from exchanging drugs, but you can remove the HIV infected one after the other. So at the end, if they use drug in the prison, there would be no more transmission. And this is true as well for other infections. As you know, they have low viral loads on suppressive therapy.
I think if I can add a comment, also the transmission in prison is not only drug users, but also tattoo. There are a lot of experience to do tattoo inside the prison, and specifically in some country. There was a beautiful movie about Russia, Siberia, I remember, And so in Italy, there are a lot of programs to study and to let the circulation, the test of HIV, hepatitis B and C on prison. So it's a big issue, I think, in all Europe. So, but drug users, of course, is a very important issue, but not only. I think also tattoo can be another issue of transmission, I think.
And sexual intercourse as well.
Sexual intercourse, of course.
Yeah. So, by the way, in Germany, we still have some interferon applications for hepatitis C treatment, and this is due to the prices and is applied in prisons. So, because of cheaper treatments, they still use interferon in prisons.
It's double
I didn't
pain.
know that. Sorry?
It's
Fake
double
interferon.
pain.
Yeah, yeah.
You're in prison and you get interferon. It's tough.
So, okay, now housekeeping notes again. First, let me say that within 2 minutes, we have to stop the session. We already got some minutes, spare minutes, and we have the possibility to meet the speaker, but Anna Maria said that she has to leave earlier, and how this works with meet the speaker, Francesca is willing to explain, and my last task now would be to announce session 5 and to remind you that at 5 minutes past 4 we start the session what's in the pipeline, and that means also what are the questions also for next year. So 5 minutes after 4 o'clock we meet for the next session, and in between we have the possibility to address questions to the speaker, and maybe Francesca, I can hand over to you to explain this. Was this correct?
Thank you. Yes, I hope to explain well, because I'm not really familiar with this, but I think there is an extra session now. If we go out from here, there is meet the speakers, and Anna Maria and Jean-Michel, Anita, myself could be there to answer some questions. And
So not me, Francesca. I'm very sorry, because
so you're leaving.
I
Okay.
didn't know that I was expected to attend, and unfortunately I'm on duty at the hospital and I have to
Okay.
to get across.
Okay, so if someone has a question to do now to Anna Maria, if not, we will do another time. Thank you for being here, and so the other could be present to the this session, meet the speakers. So thank you, Rolf. Thank you to everyone. I think it was very nice session, and if some other people want to do questions, we can meet in the other room in this meet the speakers.
I'm very happy to answer questions by email. If anybody's got any questions, please do send me an email. And my email address is very simple. It's my surname @liverpool.ac.uk.
Okay, thank you, Anna Maria. Good job. Bye-bye. Bye-bye to everyone.
Okay, thank you. Bye-bye.
Bye.
Bye.
Thank you.
Thank you.